So today we are going to talk about the pathophysiology of the thyroid diseases. We will have lectures about the thyroid diseases 2 weeks from now, and this should be added to the lecture, and this way you can accomplish the exam very easily. Now, the thyroid regulation is very important, basically about the same as the pituitary, the trope hormone, target hormones, because we do have the hormone that is synthesized by the thyroid gland. This is a T4 and T3, and they do have the feedback mechanism on the pituitary that going to regulate the TSH release, and further up to the hypothalamus to the TRH. Now, this regulation, the T4 and TSH, they are very closely related to each other and very finely tuned up. A teeny tiny biological excess of the thyroid hormone, the T4, already going to suppress the TSH level. This is why if you want to evaluate the thyroid function, usually we are asking both the T334, the free form, and the TSH together. Now, let's see something about the physiology of the thyroid gland. The T4 that is synthesized by the thyroid gland, it has a half-life about 1 week. This is why if you give thyroid hormone to the patient, within 1 week almost you cannot achieve any changes. So you have to leave at least 2 weeks or 1 month when you do see changes in the thyroid hormone level. Now the T3 half-life is short, it's maximum of 1 day. However, it's only about 15 to 20% of the all thyroid hormone that released at the thyroid gland. The T3, that's an active hormone, that's about 1,000 times more active than the T4, it's going to produce in the peripheral tissue. We do have some deiodinases in the periphery, such as, for example, the type 1 in the liver and the kidney, type 2 in the pituitary, brain, and placenta. And we do have the type 3 that is not going to upregulate the T4, however, is going to, let's see, downregulate, because this reverse T3, it's almost ineffective. In certain conditions, such as a chronic diseases, the T3, the reverse T3 level will increase. Of course, in comparing to the every other hormone, the thyroid hormone is circulated in the blood in a protein binding form, mainly bound to the thyroid binding globulin and the albumin, prealbumin, and only a fraction, this about 0.04% or 0.03% is a free form that is effect on the target gland. The free T3 level in the circulation is higher, but it's about 0.3% of the total hormone level. The negative feedback, as I mentioned, in the hypothalamus that regulates the TRH, the thyroid releasing hormone level, and in the anterior pituitary, the adenohypophysis, the TSH is regulated mostly by the T4 level. Now, what kind of diagnostic test we can apply in case of the thyroid gland? First of all, as I mentioned before, the TSH in the serum should be checked. And additionally, the thyroid hormone level, the T4, usually we are measuring only the free form. It used to be measured the total one and the free as well. But now we can measure very easily the free level. So this is what is checked. We can measure the thyroglobulin level. That's very important because this thyroglobulin is sitting inside the follicles. This kind of protein, this thyroglobulin, is locked out from the circulation, locked out from the immune system. However, if we do have any kind of damage of the thyroid gland, the thyroglobulin level can be increased. And if a damage occurs in long term, the antibody about the thyroglobulin can be increased in the situation. We do have certain anti-thyroid antibodies. I already mentioned the anti-thyroglobulin. However, the anti-TPO as an anti-thyroperoxidase or the anti-thyroid receptor antibodies. These are the antibodies that is important in case of the function or checking the function of the thyroid gland. Beside of this one, we do have some imaging technique when we do have measured the uptake of the thyroid gland, how the uptake works. These are we using the radioactive iodine because this is the only gland that uptake the iodine. So we can measure by a scintigraphy camera how this iodine is uptaken, whether that's a homogeneous or that's, let's see, some kind of warm nodules or toxic nodules happening, or we do have a diffuse uptake by the gland. Ultrasound, another very important one, especially that cystosis mass can be detected easily, or the fine needle aspiration, the cytological evaluation is important. Now the TSH, that's a level, depends on the negative feedback action. This is the single best thyroid function test. If we could measure only one hormone, the TSH should be chosen because that's reflecting any kind of changes of the thyroid gland. So in primary diseases, the TSH very highly depending on the free T4 level. Now, only usually in secondary thyroid diseases can decrease together with the thyroid function. The normal range is depending on the lab, but it's going to be up to about 5 milliunit per liter. That can be the range. So if you have a higher one, that can mean that the patient has a primary hypofunction, or if it's a lower one than this one, that can mean that the patient has a primary hyperfunction. Usually the primary cases are the most common diseases. The thyroglobulin, as I mentioned, this is where the thyroid hormone is synthesized and stored inside these colloid follicles. Usually this is called the follicular structure. Now, after thyroid ablation, the level is dropping down to 0. If the level increases, as I mentioned, that's usually meaning that we do have a disruption of the follicular structure. That could be used, for example, some kind of thyroid cancer, thyroid tumor. Now, this antibody, again, the thyroid globulin, can be checked, and in certain cases, for example, some chronic autoimmune diseases, the level is increased. Now, other thyroid antibodies, such as I mentioned, the thyroglobulin, as I mentioned, or the anti-thyroid antibody, these are the markers for autoimmune thyroid diseases. The highest level can be achieved in Hashimoto's thyroiditis, but this is not specific. Usually, there are some other markers for the further hypothyroidism, such as the iodine uptake or scintillation scan, and so on and so on. The thyroid stimulating immunoglobulin, this is the TSI, that is called, this is directed again the TSH receptor. This is why it's called the TRAB, thyroid receptor antibody, or TRAC in German, that meaning the same. And this is the cause of the diseases in Graves' Basadov diseases. When we do have an autoimmune reaction, again, the TSH receptor higher, this antibody will cause not a downregulation, but a stimulation of the thyroid gland. And this antibody can predict neonatal hyperthyroidism very easily. Now, thyroid ultrasound, it's another important test and a relatively very cheap test that can detect some kind of cystosis, some water-containing terms or mass. Usually, this can be used to distinguish a solid or a cystic mass. Cannot identify, however, the site type. It's very useful when we use the fine needle aspiration, and you can direct the needle and you can direct it to the mass that you want to take the samples from. And this ultrasound can be very useful to follow and the thyroid nodules changes, whether it's increases or decreases, and how the mass will change in time. The cytological evaluation of the thyroid nodules is used to diagnose tumor. When we do the fine needle aspiration, of course, using a guideline of the ultrasound that can aspirate, and the aspiration will show us what kind of cells we do have. And mostly the tumor of the thyroid gland, about 70% of the rate is a benign one, only 5% is a malignant one, and some other non-diagnostic, let's say, aspiration cells can be found, or indeterminate, about 10%. So as you see here, mostly the benign tumor can affect the thyroid gland. Now let's see the thyroid nodules. What kind of mass we can see in the thyroid nodules? Now, these nodules, it can be a single one or can be multinodular nodules, or this enlargement is called goiter. Now, it can be cystas, so it can be some fluid containing mass, or when we do have an enlargement of the oil gland, that can be due to some kind of inflammatory processes, such as thyroiditis. About 70% is the previous picture I showed you, benign adenoma, if it's a mass, and malignancy takes about 5%. And out of this 5%, the papillary carcinoma is very common one. We can use the scintillation scan to evaluate or diagnose these nodules. Now, here you can see 3 different uptake of the iodine. For example, when we do have this malignancy, we can have, it's called the cold nodules. Cold nodules means that this area of the gland is not uptaking the iodine, so they are not functioning. Some other one that is called the warm nodules, of course, because we do have an increased level of the thyroid hormone, then TSH level suppressed. This is why the healthy part is not uptaking as much iodine as normally. We can have the hot nodules. It's very rare, usually it's less than 1% of the malignant tumor, that meaning that we do have a very highly let's see, area that taking up the radioactivity, and the normal part is completely suppressed due to the very high level of the thyroxine. The radioactive scintigraphy that they are using, this can evaluate the anatomy and the function of the gland. This radioactivity can be technetium or iodine, and both can be used to diagnose the thyroid gland. The iodine can be used, for example, in the body, the scanning for the metastatic thyroid cancer as well, because only the thyroid cells can uptake iodine. No other cells uptaking the iodine. Now, in diagnostic process, the high uptake and the low uptake hyperthyroidism can be. The high radioactive iodine uptake that can happen in Graves or toxic nodule or monoglobular Goiter, or low radioactive uptake, iodine uptake can happen when we do have an exogenous thyroid hormone secreting gland, or in case of thyroiditis. Minimal usefulness evaluation of the thyroid nodule determine the nodule functional status as well. So whether it's working more or less, this can be achieved. Now let's start with the different diseases, and let's start for the hypofunction of the organ. In hypothyroidism, relatively what's happening in the primary, the gland is not going to secrete the hormone. This is relatively the most common thyroid disorders, and the primary, as I mentioned, this is the very, very common diseases, and usually occurs, or this is due to the thyroid destruction. Can be secondary, but these are the rare, less common, so the rare condition when we cannot have in the pituitary, doesn't secrete TSH, for example, due to some kind of lesion of the pituitary or the sella. This is what we discussed in the previous in the pituitary diseases. That can be very rare in congenital problem. Or the central or the tertiary hypothyroidism, mostly the hypothalamic disorders when we do have a problem with the thyroid secretion. Now, the diagnostic process is easy one, as I mentioned. You should measure the TSH and the T4 together. If you do have a primary hypofunction, there is less hormone. However, because the feedback is missing, this is why we do have an elevated TSH concentration. In secondary case, both level decreased. I would refer to the previous seminar about the pituitary gland, where we discuss how can we distinguish between primary and secondary using the trope and the target hormone level. In tertiary, relatively the TSH doesn't change too much. It can be elevated a little bit, but the T4 level is decreased. The best to distinguish between secondary and tertiary when we are using the TRH stimulation test, because if you give TRH, in a case of the tertiary problem, that the T4 level be elevated because the pituitary works perfectly. However, if you do have a secondary problem, the TRH cannot stimulate the TSH release. This is why the T4 level won't be altered. Now, symptoms of hypothyroidism, this is what you know very much. For the gait wane or chronic fatigue syndrome, memory loss, loss of concentration, decreased cold tolerance, constipation, hair loss, thinning the hair and loss and bradycardia and general myxedema can happen in the patient when this kind of myxedematosus picture subcutaneously increases and following it. Now, the primary hypothyroidism that can be very rare in congenital form. And this is why in every newborn baby is screened to avoid the consequence of this congenital hypothyroidism, that be the cretinism. And the cretinism, not only the linear growth is stopped, but the patient mental development is altered as well. So this can be very early, can be diagnosed. Now, thyroid cell destruction occurring mostly in a chronic form, that's a chronic autoimmune disorders, such as called the Hashimoto thyroiditis. In case of the primary hypothyroidism, immediately you should measure the anti-thyroid antibodies, such as the anti-TPO antibodies and the Thyroglobulin antibodies. Now, the radiation can cause hypothyroidism, for example, or thyroidectomy can cause, or infiltrative diseases, for example, hemochromatosis can cause. Certain drugs, basically with the anti-thyroid action, such as the lithium or iodine, high concentration of iodine, or iodine-containing drug, or radiative contrast material, or interferon alpha, also can cause hypothyroidism. Let's look at a first case. There is a 70-year-old woman and recently complains of tiredness, weakness, and constipation. Now the laboratory result shows elevated TSH concentration together with the decreased free T4 level. So immediately you can see that this patient does have a primary hypofunction. And they measure the thyroglobulin antibody, and the thyroglobulin antibody is very, very highly elevated. And this possible that's a Hashimoto thyroiditis and possible that Fiana's phase. Now, a Hashimoto thyroiditis, that's an autoimmune disorder that usually starting with a case of hyperthyroidism. When we do have the antibody that directed against the thyroid gland and disrupting the follicular structure, first, we do have more thyroid hormone in the circulation. So the patient could have clinical symptoms of a hyperthyroidism. Later on, the middle stage can be the normal function when we already destroy a certain number of the thyroid cells. However, they still have the enough cell to produce thyroxine. However, finally, when the all thyroid gland destroyed, that can be the final or the hypothyroidic phase. Now, the opposite, when we do have too much thyroid hormone, relatively the signs and symptoms can be caused by any disorder that results of an increased circulating thyroid hormone level. Now, in toxic diffuse goiter, such as the Graves or Basedov disease, that's an autoimmune disease we mentioned, can be toxic. uninodular or multinodular goiter, toxic adenoma. So these are the three most common causes of the hyperthyroidism. Now, iodine and iodine-containing drug and radioactive contrast material also can induce hyperthyroidism. Excessive exogenous thyroid hormone ingestion, for example, somebody wants to lose weight, increase the basal metabolic rate, that can cause toxicity. But painful subacute thyroiditis, that's a viral hepatitis, can cause. Or silent, there is no sign, no other effect, only the thyroiditis. There's no clinical symptoms of thyroiditis, but the level will increase. Or some trophoblastic diseases, usually that's exogenous places, the paraneoplastic syndrome, including the hidradenitis mole, when we can have thyroid TSH level increases or TRH level increases, and this is why the patient has hyperthyroidism. Now, symptoms of hyperthyroidism, almost the opposite what we discussed in hypothyroidism. Patient has weight loss, restlessness, so it's just shivering all the time. He cannot stay and cannot sit for a long time, and reduced heat tolerance, sweating, tremors, diarrhea, that's a gut hypermotility, tachycardia, atrial fibrillation, palpitation, so arrhythmias can develop, and usually proximal muscle weakness can happen in this patient. So the thyroid hormone level that controls the basal metabolic rate, that can inhibit the relaxation of the muscle, and that can be the hallmark of this hyperthyroidism. Now, to evaluate, very similarly, we're measuring the same parameters, such as the TSH, T4, and T3, and measuring the radioactive iodine uptake and the scan to see whether it's homogeneous or maybe nodular one, and measuring the thyroid stimulating immunoglobulin, the TRAB or TRAC, especially if the Graves' disease is suspected. But it's a very common one, especially in girls and age of 20s, 30s. Ultrasound and other is needed to evaluate the thyroid hyperthyroidism. Now let's talk about first the diffuse goiter or Graves' diseases. The most common cause of hyperthyroidism, now because that's an autoimmune disorder, that we do have an antibody against the thyroid receptors, as we listed here, TRAB. Now, these antibody can go to the retroorbiter area and can cause an inflammatory process and can cause enlargement of the connective tissue and pushing out the eyeball from the socket. And this is the exophthalmos. Dermopathy can be seen in pretibial myxodemas. Only in pretibial occurs this myxodema, that meaning that immunologically this area in the pretibial subcutaneous area can be similar to the TSH receptors or something. Now, etiology is not known, but looks like this is an autoimmune or the disorders, and very highly associated with the familial predisposition. Females, about 5 times more common one. As I mentioned, the peak about 20, 40 years of age. Laboratory findings, TSH decreased because that's a primary, together with an increased free T form, and the radioactive iodine uptake, it will increase homogeneously, and the free T4 level, it increases, and the free T4 index. Now, this is not measured today. We're only measuring the free T4 today. Ineffective TRH stimulation, so the TRH cannot further stimulate the thyroid gland because the TSH already relatively suppressed, so the TRH is not going to induce any changes of the pituitary. And we do have the presence of the thyroid stimulating immunoglobulin, but not only the thyroid receptor antibody is present, but the thyroperoxidase antibody can be present as well, but much less comparing to the Hashimoto thyroiditis. In some cases, don't be surprised if the thyroglobulin level, anti-thyroglobulin level increases a little bit, not too much, but only a small enlargement can be seen. The complication of this disease can be the thyrotoxicosis as a thyroid storm. When a stress or surgical or accident, it will increase the, let's see, the synthesis and release of the thyroid hormone level from the gland, and can have the patient very high heart rate, blood pressure, heat, so that the stroke can kill the patient. Thyrotoxicosis and hyperthyroidism, this is not the same. Hyperthyroidism meaning that basically the thyroid gland synthesize more hormone, and this is causing hyperthyroidism. Thyrotoxicosis means that's a clinical syndrome when the patient has a hypermetabolism that resulted when the serum concentration of free T4, free T3 increased or both increased. Now, this is not the same. If you are taking pills, for example, thyroid pills to lose weight, that can cause thyrotoxicosis. It's not a hyperthyroidism. So this is not the synonym. So if you will find these terms, you should know that which one meaning, let's see, the functional problem of the thyroid gland, or which is only affecting or affected by the level of the thyroid gland hormones. Now, thyrotoxicosis, as we mentioned before, causes Graves' vessel disease, adenoma, hormone-secreting adenoma, warm nodules or hot nodules, or goiter can be, that's only enlargement, that is meaning enlargement. Thyroiditis can be, not every thyroiditis, but mostly the subacute thyroiditis has a thyroid, hyperthyroid phase, and exogenous intake of the thyroid hormone, as I said. The symptoms of thyrotoxicosis: very high fever, vomiting, diarrhea, tachyarrhythmia, and restlessness. This is the potential life-threatening situation. In case of Graves' Basedov disease, for example, when you do have a long-standing stimulation of thyroid gland, and if you have an accident, this stress induces so much release of the thyroid hormone that can induce this thyrotoxicosis or thyroid storm. This is what it's called. Now, how can we treat the thyrotoxicosis? Basically, they are giving iodine to suppress the gland, to suppress the release of the thyroxine. They do have some inhibitors of the thyroxine synthesis of the iodine incorporation, beta blockers to control the heart rate, or antipyretic treatment to the the fever and hydration, because this patient loses a lot of fluid. This should be replaced. Now let's see the second case. If you look at the picture, you can see immediately what could be the problem with this lady. Now she is a 54-year-old. She lost about 30 kilograms within 1 year by having good appetite. The food passes through quickly, what she said, and experienced tremor and palpitations, so arrhythmias. The status when they evaluated tachycardia and endocrine ophthalmopathy, as you see here, that is the exophthalmos seen very nicely. Now they measured the lab, the hormone levels, both the free T3 and free T4 elevated. However, the TSH is very, very low, and the thyroid receptor antibody is high. So that's a direct proof for the Graves' Basedov diseases. They performed the radioactive scintigraphy and slightly larger symmetric thyroid gland with slightly increased uptake and activity of the lobe. So this is the general activity increase, and scintigraphy image of diffuse goiter. So this is a Graves' Basedov disease, and what they can use, usually the partial thyroidectomy they're performing, and timazole, that's an inhibitor of the thyroperoxidase. Now the surgical removal of thyroid gland is better because the antigen is removed from the body, so the immune response be less and less. They figured out if they used only a blocker of the thyroperoxidase in the long term, that can develop hypothyroidism, because this low-grade immune reaction, inflammatory reaction, can destroy the thyroid gland. So those patients who suffered in their age about 30, for example, a Graves' Basedov, and they treated with only drugs, so the inhibitor of thyroid peroxidase, and later on, after 30 or 40 years, they develop hypothyroidism. This is why now they're using a partial removal of the thyroid gland, and this way the smaller amount of thyroid gland is enough to maintain the normal thyroid function.